Hi friends, keeping the rhexis size between 4.5 to 5 millimeters will help you achieve the perfect phacoemulsification, and in this video I'd like to show you why. So let's analyze the rationale behind why and how this works. Understand that the size of the CCC will actually regulate how the entire phaco procedure will progress, because once you make a smaller CCC, the surgeon is forced to make more number of smaller size fragments, or mobilization of these fragments will become difficult through the smaller CCC. The smaller sized Capsulorrhexis will also help to retain the rest of the nucleus within the capsular bag while a fragment is being mobilized. This will reduce flying fragment induced endothelial damage and also turbulence in the anterior chamber. If you keep the CCC small, the anterior capsule will act as a fence or barricade, preventing the rubbing of nucleus fragments against the posterior iris surface. This will reduce intrapupillary meiosis that is associated with hard cataract emulsification, usually in conjunction with a larger size Capsulorrhexis, which we perform in harder cataracts. The 4.5 to 5 mm CCC will provide a good capsular overlap over the IOL optic edge, which will not only maintain a stable effective lens position, but also minimize IOL decentration over a period of time and reduce PCO formation. The size of CCC is also ideal for performing a stable anterior or posterior reverse pupillary capture if the need arises during the surgery. A larger Capsulorrhexis will lead to spontaneous release of this capture if patient simply rubs his eye or if the anterior chamber pressure increases. This is another advantage. And finally, performing phaco through a smaller size rhexis will increase the degree of difficulty with respect to fragment creation and mobilization. This should be remembered and therefore should be attempted by surgeons who have got the skill and confidence to carry it out and some amount of experience. The main focus will be on creating multiple small fragments and mobilizing them one at a time. Please avoid this technique in a grade 4 nuclear sclerotic cataract or even in very soft cataracts. Having said this, let's look at a video and see how this thing actually occurs in real life. This patient was being operated under topical anesthesia with a grade 3 nuclear sclerotic cataract. I'm going to use a toric lens in this patient. The pupil size is around 5.5 millimeters, and I know that during the course of emulsification with the fragments rubbing against the iris surface, there's bound to be a narrowing of the pupil or a pupil shutdown. But in spite of this, I'm choosing not to use iris hooks or pupil dilating devices. The capsule is adequately stained with trypan blue as a good red glow was not visible. The trypan blue is washed off. I'm going to perform a Capsulorrhexis, aiming to keep it between 4.5 to 5 millimeters. Since the pupil size is around 5 millimeters, I know for sure that this rhexis size would be around 4.5 millimeters when compared to the diameter of pupil. The cortical cleavage hydrodissection is done in small aliquots at multiple locations. Getting the nucleus to rotate is important while performing this case. So I'm going to perform the direct phaco chop. I'm going to use a multiburst mode of phacoemulsification. The power here is 35%. The sharp tip chopper is carried to the mid periphery. You see that as you keep the tip of the chop on the surface of the nucleus and take it to the mid periphery, it just pushes away the edge of the rhexis. There's no risk that you're going to chip or cut the rhexis margin while you perform this, because the outer surface of the chopper is actually blunt. The fact that the rhexis size is 4.5 millimeters will automatically make you achieve smaller fragments while you're doing the direct phaco chop, because if you're going to have just 4 fragments, it will not be possible to mobilize the pieces out of the capsular bag, and hence you're forced to create smaller fragments. Now once you have created 6 or more fragments which are sufficiently small, then each of these fragments can be mobilized and brought to the center where it is emulsified. Now once the chop has been completed, you then switch over to your Sinskey hook and give up the sharp tip chopper. The Sinskey hook is much safer to use. Now let's look at the various advantages of having a smaller size rhexis. The first is that you're forced to create smaller fragments to mobilize. The second is you see that the anterior capsule acts as a barrier between the nucleus fragment and the posterior surface of the iris as well as the pupillary margin. This keeps the rest of the nucleus, which is fractured but not mobilized, within the capsular bag itself, and the small fragments that come out are emulsified in the central area because that's where you're able to mobilize it into the anterior chamber in the supracapsular plane. In spite of the fact that I'm emulsifying a grade 3 nucleus sclerotic cataract, see that the pupil size is being maintained at the original 5 millimeters throughout the entire procedure. This is because the anterior capsule is now acting as a barricade, preventing fragments from hitting on the posterior iris surface. The other big advantage of having a 4.5 millimeter Capsulorrhexis is that in the event of a posterior capsular rupture, you can create an optic capture. An optic capture will act beautifully in these cases and prevent the optic from getting spontaneously released when the patient squeezes the eye or if the anterior chamber pressure rises. In larger rhexis, although you're able to achieve an anterior optic capture, this optic capture may not be secure. The good cortical cleavage hydrodissection enables good cortex removal, and finally, when you implant the toric IOL in the bag, you find that the IOL sits nicely within the bag. This is the measurement of the rhexis size. They have a graduated scale on the uterine forceps at 2.5 and 5 millimeters. So the toric intraocular lens is properly aligned to the axis of placement by a pivot rotation, and finer adjustments may be done by adjusting the IOL at the optic haptic junction. If the IOL overshoots the desired mark, then a compression rotation in the opposite direction will enable you to move the lens in the anti-clockwise route for about a few degrees. The good overlap of the optic of the toric lens by the 4.5 millimeter rhexis margin will ensure maintenance of a good effective lens position. There is a lesser incidence of posterior capsular opacification. There are therefore several advantages to performing a 4.5 to 5 millimeter rhexis, and I'm sure that it will give you a perfect phaco each and every time. And friends, these are slit lamp photographs of the patient taken 15 minutes after he came out of the operation theatre. You can see that the cornea is crystal clear, the anterior chamber is quiet, and there is a wonderful alignment of the toric IOL in place. Thank you for your attention.